All right, so thank you. Thank you so much. So, hello again, everybody, and welcome to today's session of the 2026 Global Collaborative Series, Global Nurse Force, Bridging Health and Climate Action. My name is Asia Neopane, and I'm the Director for the Office of Planetary Health and Global Engagement here at the Yale School of Nursing. This monthly event is made possible through our collaborators and our partner hosts, the staff and faculty team at the University of Michigan, led by Dr. Janae Marie Stacchiarani, Professor and Associate Dean for Global Affairs and Director of the Pan American Health Organization of the Collaborating Center at the University of Michigan School of Nursing. And also, it's great thanks to Jennifer Chapin-Smith, also at the University of Michigan School of Nursing, and the team at Vanderbilt University, led by Dr. April Kapu, Professor and Associate Dean for Strategic Partnerships and Global Affairs at Vanderbilt University School of Nursing, and Betsy Usher, the Assistant Dean of Alumni Relations, also at Vanderbilt. Thank you to our partners for their dedication and contributions to this initiative. Each month, we take turns hosting this important series, and we encourage everyone to stay engaged by registering for future sessions. The next one is also being hosted by us here at Yale, and that is on Wednesday, March 25th. So now it's my pleasure to introduce you to today's speaker, Dr. Allison Squires. Dr. Squires leads multiple domestically and internationally funded research projects focused on nursing practice, workforce development, and global health systems. In the United States, her work examines the impact of language barriers on hospital nursing practice. Internationally, her funded studies focus on nursing workforce capacity building in Greece, Ghana, and Guyana. Dr. Squires is the founder and principal investigator of the Global Consortium of Nursing and Midwifery Studies, GCNMS, which is an 87-country research consortium dedicated to advancing global research capacity in nursing and midwifery. The consortium's current flagship study examines the long-term effects of the COVID-19 pandemic on the global nursing and midwifery workforce. Prior to entering academia, Dr. Squires practiced for 11 years as a staff nurse in solid organ transplant and as a staff educator across rural and urban U.S. healthcare settings. Her clinical work has since evolved to community-based nursing roles through volunteer service. Please join me in giving me a warm welcome to our speaker today as she shares her expertise and collaborations as related to the global consortium that she co-leads. Thank you so much, Dr. Squires, for joining us.
Thank you, Asia. Greetings, everyone. It's nice to see familiar faces, either from meeting in person or on LinkedIn and various other places. I'm Allison Squires. I'm currently a professor of nursing at New York University. And it's my delight today to present to you about the story of the Global Consortium of Nursing and Midwifery Studies and building multinational research partnerships. So you'll hear me refer to the consortium as the GCNMS. That is our rather meaty acronym, but it really reflects what we are trying to do in terms as a research consortium. So to get started, so once upon a time, a pandemic happened in the year of the nurse and the midwife, and there was a lot going on. And I think nurses and midwives everywhere sort of had wry senses of humor of, oh, how ironic that a pandemic should happen in the year of the nurse and the midwife. And at the time, I was working on the Future of Nursing report when I was as the Distinguished Nurse Scholar in Residence at the U.S. National Academy of Medicine. And we were almost done with the report, just so close. And then March of 2020 hit, and we had to pretty much start over. And it became really important to document the impact of the pandemic on U.S. nurses. And so in order to do that, because publications take time, and the U.S. National Academy of Medicine, its process is really rooted in citing and using only evidence or noting its absence. So we did a study, and I worked with a great team on this, and we were able to test some interesting methods around online qualitative studies, where we were able to use both human and large language model coding as a way to study what was happening. We initially did a white paper for the Future of Nursing report, but eventually turned that into a publication. And so when I was recruiting for this study, I got a message from my longtime colleague, Dr. Juana Jimenez Sanchez, who's a former chief nurse of Mexico. I like to joke she's one of the bosses in my life. And she messages me on Facebook, where I had been doing recruiting, like so many people were doing for research online during the pandemic. And she said, "So, can we do this study in Mexico that you're doing? Maybe all of Latin America?" And hey, it was a pandemic. I was home and not traveling like everyone else. And but I still had all of my international connections through 20 odd years of networking. And ironically, you never know how long your relationships will last. I had first met Dr. Juana when I was a PhD student and doing my dissertation work in Mexico. And so when we were collecting data there, when I was collecting data there, she was actually a great support to me. And over the last 20 years, we have maintained this connection. And basically, if she asks me to do something, I can't say no. So that's why I say she's one of my bosses. But she poses this idea: can we do this study in Mexico, maybe all of Latin America? And she was organizing with a group of young doctoral students in nursing in Mexico and Colombia this huge Latin American network to advance nursing education and research capacity building in the region. And I thought, well, that's got good possibilities. So, and I was also, being a global health nurse, I was tracking the literature on nurses and COVID, and it was becoming pretty clear by the end of 2020 that there were too few, if any, studies coming out of low and middle income countries. And because of that, it sort of hit the point where it was like, wow, somebody should really do something about that. It's purely cliche. Somebody should do something about that. And then I realized, well, it turned out I was someone who could do something about that. But the question became how? How are we going to do this? And if we're going to do this type of study, it needs to be rigorous. It's got to work within the limitations of both resources and technical skills of potential partners. And I may be working with partners that might not have much research experience, because I'm very well aware of the strengths of research capacity in different parts of the world within the nursing profession. Even in some high-income countries, you don't have a lot of nursing research going on. So it's both places where there was lacking research capacity, but even in places where there just wasn't a history, especially around health services and workforce research. And in our field, multi-country studies, especially from nurses in low and middle income countries, are not that common. And so it became really important to think about, how do we do this? And please apologize for my coughing. I'm here in Guyana working, and the air quality has been a little bit challenging due to Sahara wind dust. So, hey, you never know when these things happen. But back to talking about this study. Data, one of the things that became critical was we needed to make sure that the data was going to be in the language of the participant. And I'm particularly sensitive to this as a bilingual Spanish-speaking nurse, in that, Latin America is often left out of a lot of things because there's not a lot of English speakers in the region, and there aren't enough Spanish speakers in other parts of the world to really develop collaborations and research. And so because of that, it became important to have data in the language of the participant. Now, I had worked on a lot of studies before this involving language translation, including survey research and qualitative research. So I wasn't afraid of the translation thing. I knew I could handle that. But the other thing that became important was to not duplicate what was already being done elsewhere. And there's a ton of people doing stuff in the clinical education space around that. And I'm like, well, because there's so many people doing that, I don't want to go into that aspect. I really want to think about research capacity, because that was where I saw the gap. So the answer became create an international research consortium. And so there's an international research consortium. You can have a lot of ways to do research or topics to do research. But what I was seeing during the pandemic was there was a gap in health services research capacity in nursing and midwifery. So the idea was build researchers with this capacity to do this kind of work in their countries. And, we want to make sure that any nurse who wants to participate in this consortium is building skills and knowledge to conduct health services research that improves patient outcomes. Because you can have all of the interventions in the world and figure out how to help people manage their symptoms, but if you don't have workers to help implement them, it's not going to matter what your intervention looks like. You still need people to deliver it. So our consortium values are rooted in the concept of reciprocity. And I knew going into this that I would have very little money to do this work, but it was such a dire need that I was like, well, I'm going to do it anyway. And so, if I was asking people to participate in this study and collect data, I wanted to make sure that they were also getting something else out of it. So as one of the things that I've been doing as part of this is I will do a webinar on a topic of their choice, usually around health services research. And it's been a whole range of topics that for the webinars that I've done, from basics of evidence-based practice all the way up to global nursing workforce studies, or topics about immigrant health, because immigrant health is a global topic. And so in terms of our values, they all come from this idea around reciprocity. So, we want to make sure that, within the consortium, people are fostering multinational collaborations, that if they are collecting data for a study that we have mutually agreed upon, that they own their own data, but they're contributing to a multinational database, and that the country authors, they're going to lead papers and presentations. I certainly can't be in all the places of 87 countries. So that was a really important thing, that the country authors lead the papers. And, we can provide coaching for novice researchers on how to do this. And our Latin American teams in particular have been absolutely amazing in how they have organized to support coaching and mentoring people to do research in this space. And, if we are doing a multinational comparative paper, everybody's a co-author as long as they meet the criteria for the ICJME international guidelines. And for ethics approval, it's whatever the rules are in the country. And, it was one of those things, yes, that delayed in many cases, sometimes up to 6 months, the data collection process, but it was really important to just respect the rules of whatever that it was in the country. And we also wanted to encourage people to pitch ideas for new projects. And we've had lots of people pitch ideas for new projects. People have jumped together and collaborated and started creating new ways to collaborate. And, the other thing was, if we miraculously happen to get grant funding, is that if it came from a country, especially an LMIC country, that grant funding stayed in the country and supported that work there. And I'm taking full advantage of my status as a tenured full professor and my privilege that is afforded by that position, and making sure that could happen. So we are up to 87 countries and counting. You can see this is the scope of where our members are. Some have been actively collecting data for our COVID study. Others have just been participating in the research methods webinars that we've been offering. And so it's been really fun to see this grow and the map fill in over time. And you can see really our emphasis is on low and middle income countries for the most part. But we've also been able to create some nice relationships between high income countries and our low income country partners that were outside of where they were already working. And this is almost everybody who is part of our teams right now. And I'm always paranoid that I've missed someone. So if someone is attending and they don't see their name, I apologize. But they do. You can see these are names that come from all over the world and all different regions and languages. So now back to that COVID-19 research challenge. So we needed to pilot test after figuring out, all right, well, I've got willing participants to do this from partners that I had been already working with. And so we decided, all right, we're going to do this pilot test. And so we had 13 countries involved and 9 languages. And so it was still at a time when people were responding to online surveys because there were still social restrictions. And so we did this online qualitative study where we had 1,800 roughly valid participants who generated 6,483 qualitative data points. Now, you can imagine that there are not enough doctoral students between all of our countries in the world to code that many qualitative data points. And so this is where we have started to leverage the topic modeling approaches from our pilot study to do this analysis across the languages. And we could do translations, but topic modeling is really cool because it can actually work across languages and produce topics that are conceptually similar, even when you have multiple languages involved. So we had our pilot test that helped establish what we had, the overall methodology, and that we were, something that we didn't have to worry about self-plagiarizing when starting to publish from other countries. And what we learned in that pilot test is the importance of a country-based team. It's like, yeah, you can recruit online and you can probably get valid results most of the time. At the time, bots weren't as bad as they are now when it comes to online research. But, when you have that country-based team member, there's a personal connection to the people that you're recruiting. I'm not just some random white American woman who is saying, hey, would you complete my survey, by the way? So, that importance of that country-based team and that cultural entree was really important. And it also, gave legitimacy, like, oh, my country's participating in this multinational study. So that was a big selling point. Something, I don't know what happened during the pandemic, but translation software has improved dramatically. If you speak one of the languages of greater diffusion, like Spanish, Arabic, Russian, the various dialects of Chinese, and other widely spoken languages, you can get a pretty solid translation for those languages. Now, if it's a language of lesser diffusion, like Somali or some Asian languages where they're not as widely spoken, the translation is not as good. And so, we think that this is, AI translation can be a solution, but it's really based on where is the market going. And so it's going to be the most widely spoken languages first. The languages of lesser diffusion are not going to translate as well. And we found that with the machine translations. And our teams were like, I said to them, like, is this translation any good if they had a language of lesser diffusion? And they'd be like, no, it doesn't work. So they would have to do their own translation. The other thing that we learned is that nurses and midwives can do anything with a good protocol. So if we had a really solid protocol put together based on what we had learned, and so if you gave them, here's how you approach people, do data collection, here's the strategies that we have seen work in different locations, they'll go out, they'll do it, they can get it done. And so that was really important because we do have roughly about half of our teams have members who have never done research before. So that was really an important piece to learn and think about. And, because nurses are used to following protocols, why couldn't they follow a research protocol? And, we can set these things up to collect data internationally with pretty minimal resources. If you have an internet connection and a solid online data collection program with appropriate protection against bots, it's pretty minimal in terms of data collection, but the analysis is a lot. And so that is something that we have to plan for. And like any good qualitative study, you can get the data, but the analysis takes a lot more time. So in 2022, with those things in mind, we decided, let's just open this up to any country with a willing team. No previous research experience needed. We updated the protocol to reflect the later stage of the pandemic and post-vaccine availability, and again, maintained that aspect of ethics approval for country rules. We were constantly updating our IRB approval at NYU. So every time we added a new team, we were adding that to the IRB. I think the IRB people were just like, oh my God, more people. But they acknowledged the work that was being done. And so that was how we kept adding people. And people would indicate if they had accepted the NYU IRB approval per their country rules. So here, I'm going to share a few results and insights from our COVID-19 study. There's a lot of fun, interesting information, and we are swimming in data, and our teams are really working hard in terms of getting this information out. So over time, we started this wave of the data collection in 2022, and within about 6 months or so, we had about 6,000 plus participants, and this was largely from our Latin American teams, who, like I said, have been amazing and incredibly organized. And then in 2023, we ended that year almost having just over doubled our number of engagements with the surveys. And right now, we're still collecting data through 2026, and we're hovering close to 23,000 engagements with the survey. Now, I say engagements very intentionally because these are people who, went through, said yes to the consent, but there are people who just didn't end up answering any questions. So that was fine. And, that's going to happen. That's survey research. And so our actual data set right now is we have about 14,000 participants from 103 countries who have completed about 60% or more of all of the questions. And so that's a pretty amazing amount of data, and it's really incredibly rich. And one of the things that we've noticed in their open-ended free text responses over time is that we see a shift in the language being used to people being more reflective and insightful about their experiences. And so we're pretty sure this is the largest data set in the world on nurses, midwives, and the COVID-19 pandemic at the moment. And so here's some of the analysis that we did with the topic modeling. So you can see that there are peaks and waves of the different topics. So the top LLM, a topic will cluster. These are words and phrases and sentiments that come together and they form a topic. And the computer identifies a topic and what that is. And so what we see over time is changes in where these topics peak and what nurses are talking about most often. And what's interesting is if we overlay the COVID-19 peaks and waves, what you see is usually a peak in pandemic disease incidence right before the peak in the nurses' responses. So you'll see a peak in a COVID wave, and then that'll start dropping, and then the nurses' responses go up. And, our teams concluded it was like, well, yeah, because they're working in the clinical setting and they don't have time to respond when there's a peak. And so afterwards, that's when they start responding. So they're, responding when they have time. So that was an important insight when we're thinking about how do we collect data during a pandemic, because, the COVID pandemic won't be the last one. There will be more in the future. So in thinking about pandemic preparedness in the future and collecting data, this is important. This is an important thing to note. Other ways that we have been looking at our data is, different visualizations using the topic model. And so we can see where things overlap, the darker the color, the more overlap that there is with this similarity matrix on the right-hand side of your screen. But you can also see that how things sort of manifest topic-wise and where they cluster over in the other BERT model, which is the dots over on the left there. I am still learning the technicalities of this. I've been working with some great data collaborators in computational linguistics and data science, and so this is really this has been a huge learning curve, but it's really, really interesting figuring out what can this LLM-based analysis do, but also where is it still important to have a human involved. And trust me when I tell you, it's still really important to have a human involved. So, part of this is we don't trust the computer entirely, so we still have humans doing summative content analysis. And summative content analysis is where you can count the frequency of something happening. And this becomes important when you're looking across countries, because not every country is going to be talking about the same things. But, things that we saw, this is results from like across all countries in terms of what nurses were talking about. Some of these things, there's no surprise. Everybody was experienced increased workload. There was a lot of stress related to work to role changes, and in particular for ICU nurses who were dealing a lot. But, other annoying things like, more than half of our nurses reported that they were doing more housekeeping tasks than they were before. And, almost half were reporting that they were working when physicians did not have to. But, sort of a good light here, especially in terms of thinking about advancing the profession, nurses were reporting in 64% or more that they had increased autonomy and, of course, more responsibility that goes with that, which really, to a degree, is creating a shift in roles for nurses. Now, of course, there's not actual increase in pay to reflect that, but, one thing at a time here. And so another one of our studies that came out this was our first big, full consortium study, was we took a look at our self-reported mental health symptoms during the COVID-19 pandemic. And for many nurses in low and middle income countries, or many countries, this is the first occupationally specific data about nurses' mental health around, their symptoms for anxiety and depression. And this study was really interesting in terms of the issues it revealed for measurement of nurses' mental health, because interestingly, not surprisingly, nurses don't want to say that they're anxious or depressed, but they'll be happy to tell you that they have all of those symptoms. And we know this is partially the broader stigma around mental health, but also the fact that, I think there's a stigma associated also with the diagnosis, and what does that mean for work? And does that make them more vulnerable in their workplace in an already precarious time? So, when we look at these symptoms, you can see that, people were okay to talk about anxiety. And we asked them about anxiety at work and at home, because we know many, in particular, many women were taking on more family responsibilities in addition to working during that time. So you can see that, work was in most cases the primary source of symptoms, stressful symptoms or symptoms affecting their mental health. But, home could also be almost equally as stressful in some cases. And so, this is interesting descriptive data, but we wanted to take a sort of deeper dive. And, we have different sample sizes across countries and regions. So we've been doing these funnel plot analyses because, we were trying to aim for 300 participants per country, which was good for statistical comparisons, but we don't always get that. So we have a great statistician, Dr. Simon Jones, who has been figuring out how to manage these data complexities. And so his suggestion was to look at these on a funnel plot performance of looking at, how were people reporting, for example, in this graph around anxiety. And what was fascinating is if you are above in the red, you are reporting more anxiety than other places. If you are below in the green, you are reporting less anxiety than other places. And, in the middle, you are kind of falling into the norms. And what I find fascinating about this graph is there is no cultural pattern whatsoever in terms of where people are landing and where their symptoms are landing. Now, interestingly enough, our colleagues in Kosovo said, well, compared to what we've been through previously, most of the time, what's happening now, it's like it's not as anxiety provoking as having been in war. And so it was one of those things where this is where your team members become really important for providing context for some of the responses or analyses, or the relativism of the analyses. Same thing about symptoms of depression. You don't see any cultural patterns except, there's hints of, well, maybe depression is very stigmatized, for example, in Poland, with so few nurses reporting feeling depressed at work in terms that way. But, Mongolia on both anxiety and depression is really high up there. And we've been talking to our Mongolian teams, like what's going on, what's the story there. And so now that they have data, they can actually work toward addressing those issues. This project around violence and aggression, because we asked nurses, have you experienced violent or aggressive behavior from the public during the pandemic? And, for those who said yes, we asked them, well, please explain, where did this come from, and in free text response. And so I had a brilliant young undergrad named Crystal Bake, who was really interested in this topic. And I was like, okay, well, I'll teach you how to do this. And she was collaborating with another nurse who was doing her MPH. And so they started doing content analysis. And so we have some comparisons across our data. And what's interesting is you'll see that, in lower and middle income countries, there was more acts of violence or aggression around resources or patient experience for long wait times or a lack of staff. But as we move into higher income countries, what we see is misinformation and a lack of staff really being causes of violent or aggressive behavior from the public. So we are still diving more deeply into that right now, because it was this graph that tuned us in through that human-based analysis of, oh, we need to be looking at this and comparing across countries around what's going on here. So these early descriptive analysis have been leading to more in-depth results. And if we group the countries in terms of whether they say yes or no, what we see is lower income countries have lower levels of reported violence and or aggression from the public. And as you reach high income countries, you tend to run into more than half of the nurses reporting that they're experiencing violence or aggression by income by country level. And so that was also an interesting insight in what is it about those aspects. Perhaps it's greater access to the internet and misinformation that is the source of these issues in high income countries. Again, requires more exploration. And so we asked nurses about their sources of stress in an open-ended question: what is your greatest source of stress? And so as we did the initial qualitative analysis, because this was a big topic of interest for all the teams, what we saw is as there was this layered levels in terms of the themes around where did the center start, which was often around their inability to do more for patients given what was going on with them. And then these layers of stress were added on by patients and families, lack of resources, whatever they happened to be. And every country could have a lack of resources. It was not exclusive to low and middle income countries. There was also the physical stressors. Nurses often talked when we're thinking, and this is important when we're thinking about climate change for the future, about the physical effects of, in particular, wearing PPE in hot conditions where it was difficult to breathe and you couldn't drink or eat for most of the day. And so places where they did not have air conditioning or where the temperature had been increasing because of climate change, we saw more nurses talking about these physical challenges with working during a pandemic. Practice changes were also stressful, but it was more the stress associated with they wanted to do right by the patient, and not so much that there were the volume of practice patients. And of course, the workload with everyone working more and taking care of more patients who were much, much sicker. And so when we take just the individual sources of stress, which is that top circle in that Venn diagram, the other three thematic areas, of course, were around PPE, whether or not it was accessible, useful, et cetera, the risk, their personal risk for getting COVID and possibly bringing it back to their families, and then how their employer and country were implementing pandemic response protocols. So you can see that, the mental health consequences were coming qualitatively from, we're putting it out there that it's coming from these intersecting sources of stress during the pandemic. And for those of you who worked during the pandemic, this probably resonates, or at least I hope it does. So what's nice is that our data is really aligning quite well with the WHO Pandemic Accords priorities. If you are not aware, the World Health Organization passed the Pandemic Accords last May, which is going to be an international agreement of how do we strengthen country level readiness for pandemic preparedness. And when we're looking at the article, there are a number of articles in the Pandemic Accords, but our data in particular has policy implications for numbers 4, 5, 7, 9, and 10. And, the fact that we've been able to capture some of the first occupationally specific mental health data is really important because, before you can start changing policy, you have to have that data. And so having data, these are tools for our nursing colleagues in the consortium. And we also have gotten lots of insights to methods challenges that are going to be arising with multi-country studies. And most importantly, and I hope you can appreciate this, we did this all for about $35,000 in pilot funds. Our colleagues in Brazil were successful in securing $10,000 in funding there. And, this is a message, especially in these times where sometimes you just can't wait to do research. You've got to do it because it's necessary to document what's happening and find solutions. And the way that the internet has evolved in response to the COVID-19 pandemic, people have better internet access than they ever have had before. So it makes these types of collaborations even more possible. So we didn't want to just stop at COVID, and there was some kind of magic happening as a result of this study. So we started thinking, what could we do next? And so I pitched to the team, what about a nursing human resources development index? And they were like, okay, we're intrigued. Tell me more. And so we know that when we are thinking about creating a sustainable nursing workforce, that there are common global challenges. First is around data quality. It's poor, but it's improving, and it's not often publicly accessible. We don't have a common measure of nursing roles. There are things that are common for what nurses do across countries, but when you look at how technology enters the workplace, then this changes what nurses do and their level of responsibility. And we don't have a publicly accessible global repository of nursing education programs and what people are taught. So that also presents a challenging. And I don't know if you know this, but the nurse to population ratio includes 5 types of nurses and 2 types of midwives. So when you look at a nurse to population ratio in a country, that is 7 types of nurses. So you could have a country that has entirely like nursing assistant level nurses, and you can sort of wonder, like, well, what does that translate into outcomes? And so, if the nurse to population ratio includes that, we're not really understanding what type of skill mix in nursing and midwifery do we actually need to have optimal outcomes. And yes, there's a lot of research that shows the bachelor's degree is an optimal place to get, but the question becomes for a lot of countries, how do we get there? How do we help people get there? Because that's going to be part of the outcomes. But don't forget that bachelor's degree is one variable in terms of it helping to reduce risk for poor patient outcomes in the hospital. How that translates elsewhere, it needs further explanation. So if we're thinking about how do we produce nursing and midwifery human resources, there are a few key factors. Obviously, your quality of K through 12 education, that's going to be your foundation for people entering into the profession and the skills that they're going to be working with. Women's access to education. Yes, we want more men in nursing, but if women don't have access to education, which is still the case in many countries, or they're discouraged from pursuing, education after high school, then that's going to be a problem for creating more nurses. The other thing is a lot of nursing curricula haven't been updated in a really long time, and they're not reflecting, international standards for best practices. For many countries, multiple pathways to entry has to be the way to go in order to sustain their nursing workforce, because it also, once you hit a bachelor's degree, it is much easier for you to migrate. So this whole pathway to having mostly bachelor's prepared nurses, once you have that bachelor's degree, it's a lot easier to migrate to other countries. So if you're going to have a sustainable nursing workforce, you still need multiple pathways to entry. The other thing is, we know there are nurses doing things around the world that are well above what the regulations say that they can do. And these things haven't been updated over time. And so it's important we need to start capturing those differences. And then also, like, how are the institutions in the country able to support professionalization, the development of advanced practice roles, career advancement opportunities, ways to, build and grow as a nursing professional. And of course, remuneration that supports economic well-being. Now, I don't know about you all, but I have yet to meet a nurse anywhere, except maybe an administrator, who thought they got paid enough money. And so I couldn't ask people in this study, like, do you make enough money? Do you think your salary is adequate? Because I know everybody's going to say no. So the idea, though, was we asked people, what is your salary? And, then we were doing some analyses, and we were looking at this idea of economic well-being, which is your income enough for you to essentially live comfortably within the middle class of your country? And so we're trying to think about what is economic well-being for nurses, because nurses are so key to economic well-being, because one of the drivers for economic well-being is having a healthy population. So we decided what we would try and tackle is a comparative international index to look at what makes a sustainable nursing workforce. And our theoretical foundation for this work is the human capabilities approach to development. The idea is you are promoting people's ability to live whatever kind of life they want to live. It's distinct from the human capital approach, which is really focused on systems of production. This is really a theoretical perspective from helping people to thrive, both the nurse thriving and then those that she serves. And so the idea is we could also, through this index, we could provide a standardized picture of the state of the nursing profession's development in a country. Because as I have worked with governments and NGOs around the world, the thing that I'm very tired of hearing is, well, we don't quite know what to do with our nurses, or how do we make our nurses, fix our nursing situation, and or they focus only on production, they don't focus on retention. So the idea is we know these international indices are really helpful for countries gauging performance. So like the Gender Development Index or the Human Development Index that are housed at the United Nations. So if we can do this and create this comparative index, we can really understand differences around roles and scope of practice. We can help target investment in the profession more efficiently. And more importantly, the vision is put the workforce data in the hands of nurses and midwives and teach them how to use it to advocate for growing and appropriate investments in their profession, so that whether their professional organization is the one doing the investing, or if it's a government or an international aid donor, whomever, doesn't matter. They know where to do that investment in nursing. So we've done some of this work so far this past year. And, we are going to be doing a modified Delphi approach starting in May. And, it's been very exciting. And our initial meetings were really fascinating, listening to the different perspectives and experiences, but also the commonalities that nurses share across countries. And so it's been a very exciting way to move forward. And of course, we are hoping to find funding to do this, but we have a commitment from a lot of people to actually pursue this pursue this project no matter what. But, when you have multinational partners, you also have more sources and ways to access funding. And so after 5 years, we have the first project, we have our new project. What's actually been the impact? And so this is a little word cloud from our 5-year evaluation. And so we've had kind of pulling this together and really looking at what's been the impact of our consortium so far. And, we have had more than half of our members have new research partnerships or international collaborations with people they hadn't known before. We've had 12 peer-reviewed publications from our group, about 48 conference presentations across 23 countries. 20% of our members have had 2 or more publications come out of this work. We've had 35 graduate students using data for theses or dissertations, 28 undergraduate students that gained research experience. We have 19 early career researchers working with the data. About a quarter of our members were promoted in their jobs within academia or within other locations. And of course, many, many, many letters of recommendations to support people doing this work. And I wanted to share just a few quotes from our current impact survey. But what you'll see is people were, and some of these are translated. So, when looking at what they did, what people were talking about it was really this opening up to their eyes of, here's what we share commonly as nurses across the world. These are skills that I can actually take at home to really affect change and policy in my home country. And also helping them to show the value that nursing adds to the health system, which, is a constant ongoing battle, and every country is in a different stage of that. And of course, we have ongoing challenges. I mean, we can't publish fast enough. I tell my team members, you don't have to include me as an author. Trust me, I'm going to delay your publication because I've got so much going on. So it's really been about encouraging teams to, try and get their data out as fast as possible. We have a lot of journals that don't think COVID or pandemics are relevant anymore. And so, that is a problem. And and for some of our countries, especially our sub-Saharan African countries, we have very limited data because we did not have enough funds to give people money for participant incentives, because there are just not the resources in these countries. And weirdly, people don't want to spend their phone minutes completing our survey, and nor would I expect them to do that when you need phone minutes for doing more important things like communicating with your family. So, and the other thing that we're starting to see is there's new risks for online data collection due to bots and AI. And it's really easy to spot when somebody basically plugged a response into an AI to participate in our study, because it produces pretty much exactly the same response, like word for word. So, when we get those types of responses in, we tend to throw out the data altogether, because we know we can't trust it. So with that, that is where we are. That is the story of the GCNMS, and we have a lot hopefully to do in the future. And I'm really excited about doing this at this stage of my career, and just get so much out of working with these teams. And I can't thank all of the teams enough for all of the hard work that they've been doing, and just showing up and attending meetings, and finding ways to engage. So thank you all for your attention, and I will stop sharing and we can do questions.
Great. Thank you so much, Dr. Squires. Congratulations on such an amazing consortium, and with so many countries involved as well, and partners involved. I do have a few questions, but I'm going to open it up to folks who might want to. Oh, yes, Dr. Kapu.